Good afternoon and welcome to the Northeast Telehealth Resource Center Summer Webinar Series. My name is Danielle Lauder and I am the Program Manager for the NETRC. And I must admit I am a little bit in denial because I do know that summer technically ended yesterday, but I'm going to go with that. This is our last of 4 fantastic summer webinar sessions. We have had a wonderful group of speakers, and we really appreciate our speaker, Dr. Prema Menon, being here with us today. I'm going to introduce her in just a moment, but at first I'm going to cover just a couple of logistics in regard to Zoom in case folks haven't used it in the past. It's pretty user-friendly. If you look down at the bottom left-hand corner of your screen, you're going to see a couple of different icons. I will ask everybody to please mute their own microphone, and that's just the first little button on the left that looks like a microphone, and if you click on it, it mutes it for you. If you're like me, because we're putting this webinar during many folks' lunchtime, if they're on the eastern side of the United States and you would like to shut your camera off because you're trying to eat your lunch, etc., you can just click on the little icon that looks like a video camera to stop your video, and then no one will be able to see you. And then I also want to point out on the bottom, more toward the right, there is a chat button. If you click on the chat button, whether you have a question around technology, if you're having issues with your technology, your sound, your video, you can type in your question or your issue there, and we do have technological assistants on the webinar with us today, and they'll get right back to you with some possible ways to alleviate that issue. Or if you have a question for Dr. Menon, you can put your question in the chat, and we'll be looking at those at the end of the webinar. And she will be able to answer those and or follow up with folks after the webinar with content-specific questions. And then one more thing that I want to point out, at the top of your screen, there should be a little down arrow next to the word more. If you're having trouble seeing the entire screen, if your screen looks a little distorted on your end, you can click on more. And there's actually an option to fit to screen. If you click on that, it should fit very nicely into your screen. Some of us have larger and smaller screens, and we want to make sure that you can see all the slides very well. So those are the Zoom logistics. I want to also introduce our NETRC team and also talk just a little bit very quickly about what the telehealth resource centers do and how we are funded. We do have a brand new project manager, Andrew Solomon, just started with us last week, actually, so we welcome him. Dr. Terry Rabinowitz is our co-PI, and he is a practicing psychiatrist and does a lot of telepsychiatry. It has a great deal of expertise with Fletcher and the University of Vermont. Judy Amor is our telemedicine grants administrator, and Dr. Michael Edwards is our expert consultant out of the Regional Medical Center at Lubeck. What are telehealth resource centers? We are federally funded through HRSA's Office of Rural Health Policy. We were originally established in 2006. There are 12 regional TRCs who are sort of responsible for provision of telehealth technical assistance to the folks within their region all over the United States. And we have 2 national TRCs which have specific expertise. Our technology TRC is actually located out of Alaska, and our policy TRC, who has a ton of great expertise and resources specific to telehealth policy, which we know is a very real issue and one that is often cropping up on the table. They are located out of California, but all of the telehealth resource centers have access to each other's resources and expertise and share that very readily. So, you know, even the Northeast Telehealth Resource Center, we have access all across the United States to many more resources. This is just a map that shows you where all of the different telehealth resource centers coverage areas are. We need to update this map because as of September 1, we are refunded through the Office of Advancement for Telehealth and HRSA, and we will be sharing the state of New Jersey with the Mid-Atlantic TRC, which is located out of Virginia. So now we have all 50 states covered by telehealth resource centers. And we also have the American territories in the Pacific, such as Guam and the Marshall Islands, covered by the Pacific Basin Telehealth Resource Center. So you can see a very wide breadth of coverage. And just a little bit about the mission of telehealth resources centers. I alluded to this a little bit before, but we are really committed to helping anyone who wishes to establish or expand a telehealth program reach success. We know it is not easy. There are great models out there. We have access to some great content experts, subject matter experts, protocols that have been developed, etc. So it really doesn't matter where folks are starting, whether they're just learning about telehealth or whether they're seasoned veterans and really want to take their program to the next level. That's what we're here for. We are mandated from the Office of Advancement for Telehealth to assist healthcare organizations, healthcare networks, healthcare providers in the implementation of cost-effective and evidence-based telehealth programs to serve rural and medically underserved areas and populations. There's a link to the Global Telehealth Resource Center website at the bottom of that slide, and it's a fantastic compilation of resources, and it also links you to all the other telehealth resource centers, as well as some great national resources around telehealth. We do say that we're focused on rural and underserved areas, and as time goes by and more folks are working with telehealth on a day-to-day basis, we hope that stipulation sort of goes away, because we're all just recognizing that telehealth is a fantastic tool to use to increase access, reduce cost and burden on patients and providers, etc. Because we know sometimes it's just as difficult to travel and get to appointments in urban areas versus rural, etc. So that's our goal for the long term, if you will. Just some very brief details around what types of assistance TRCs and specifically the Northeast Telehealth Resource Center can provide to folks who are looking to implement programs. Nuts and bolts of implementation, program design, clinical protocols, best practices, workflow. We know that this needs to fit in with your existing workflow. It's yet one more piece of the puzzle that helps you to increase access to your patients and with providers. So it needs to fit into that existing workflow. Reimbursement policies, equipment selection, funding and sustaining your program. We have a lot of great, as I mentioned, subject matter expertise and resources around specific clinical applications, telepsychiatry, behavioral health, palliative care, which we're going to hear about today, pediatric critical care, and teleneurology. We can connect with peers nationally, as I already mentioned. Reimbursement and other policy issues are primary questions that we typically receive from folks, and then training, of course, related to telemedicine. So without further ado, I am going to introduce our fantastic speaker for today. Dr. Prema Menon is Assistant Professor of Medicine, the Division of Pulmonary and Critical Care Medicine, University of Vermont and Fletcher Allen Healthcare, which is the teaching hospital for the University of Vermont College of Medicine. Dr. Menon is a board-certified pulmonary critical care physician with expertise in end-of-life communication in the intensive care unit. She's the principal investigator on a National Palliative Care Center career development grant using telemedicine as a tool for early palliative care and family conferences in critically ill patients with a high risk of death. She is currently working on earning her PhD in Clinical and Translational Science from the University of Vermont with a focus on qualitative methods of research. And we are very happy to say that Dr. Menon, along with her colleagues, Dr. Stapleton, Dr. McVeigh, Dr. Rabinowitz, have just published an article in the American Journal of Hospice and Palliative Medicine. And the title of that is Telemedicine as a Tool to Provide Family Conferences and Palliative Care Consultations in Critically Ill Patients at Rural Healthcare Institutions, a pilot study. And Dr. Menon has mentioned that she is happy to share the link to that particular article. Her email is included in the contacts slide at the end of the webinar, and she is very happy to share that. So again, without further ado, thank you so much, Dr. Menon, for sharing your expertise with us today, and welcome.
Thank you, Danielle. Thank you very much for having me today. I love having the opportunity to kind of talk about this research, which I've been pretty passionate about for the past few years, and which is kind of gaining some more momentum over the past several years. And so before I get started, let me make sure I know what there we go. Okay, so as Danielle mentioned, I'm going to be talking about kind of how this project that we started about using telemedicine to provide family conferences. so I have no disclosures to reveal at this time, and I'm just going to go over a quick outline so we can understand what my goals are for this discussion today. So we'll talk about a brief introduction, talk about this pilot study that we did using telemedicine to conduct family conferences, and then some of the steps that it's taken for me to really get this established here at Fletcher Allen included not just the pilot study, but really assessing clinicians' perceptions, really getting stakeholders' understanding of telemedicine so that we can overcome some of those obstacles, and then a trial that we used using telemedicine, and then finally I'll discuss a little bit more about some ongoing research here at Fletcher Allen. But with regards to the introduction, I'm going to start by talking about why all of this came to be, and I'm hoping not to belabor the issue, but I do think it's important to discuss it because this truly is a novel use of telemedicine. And so specifically, we'll talk about why I feel like end-of-life care in the ICU is such a big issue. What about utilization of resources at the end of life, and then how important communication are with regards to quality of care in these patients, and how telemedicine can actually help kind of get that common point of all four of those things, of kind of solving problems among all four of those issues. So to begin with, how I became really interested in finding a way to help us out was, we know in the ICU that we admit several patients all the time that have diagnoses that we know have very poor outcomes. These are things like end-stage liver disease, multi-organ failure, metastatic cancer with organ failure. And as ICU physicians, we know that we're pretty good actually at assessing how from the get-go, how ill a patient is, kind of assessing their prognosis going forward. Despite that, though, despite that ability to recognize those who are not going to survive a hospital stay, 50% of all hospitalized deaths and 20% of all U.S. deaths are occurring immediately after or during an ICU stay, which means to me that though we're able to identify this, there's some kind of a gap in us not doing really aggressive therapies towards the end of life. And we know that this is, when it comes to utilization of resources, we're using about 10 to 12% of all healthcare expenditures are utilized at the end of life, specifically within the ICU. And this is Medicare data that I'm talking about. And so how does communication play a really important part in that? We know that patients who are aware, if they're told that they're going to die or that their prognosis is such that they're going to die soon, they would actually prefer to die near home. And so hearing this is very important for them. And we know that things that really allow us to align our care with patients' wishes are physicians supporting those wishes, family support, adequate symptom control, and then hospice enrollment. And so being able to provide that in some form is always very important. And we try to do a pretty good job of doing that here within our hospitalized patients within our own ICUs. Despite that, despite knowing all that and trying to really improve our communication, there's still a lot of work to be done. Interestingly, family members actually view within the ICU communication skills actually even more important to clinicians or to physicians' clinical skills, which I think knowing that makes the project that I'm trying to that I've been working on even more important. So we also know that within our own institutions, so without thinking about using telemedicine or without thinking about patients who are from far away, within our own institutions, when we do try to discuss kind of prognosis with family members, half of these families leave these meetings not really understanding what's going on. They don't know prognosis, they don't know diagnosis, and this is even after about a 30-minute family conference with a physician. And so there's a lot of work yet to be done with regards to communication. And of the work that has been done, what we do know is that efforts that have been done to improve this have actually improved satisfaction scores among family members, and that really structured approaches to conducting these conferences have been useful. And I'll get to that a little bit later. I'll get back to that concept a little bit later as we as I talk about the project. And so once again, these are some important points that kind of led me to why this project was so important to me. But physicians tend to wait to begin these conversations about treatment preferences until really there are no other treatments available, which isn't exactly the right time to be doing these, having these conversations, because we're kind of stuck in a hard situation. And I'm going to just mention this one more time because I think it's the most important point of everything, and that is high quality and structured communication overall improves psychological outcomes and outcomes among patients as well. So when I say psychological outcomes, I mean psychological outcomes of family members who are taking care of dying patients. And then, so that's kind of why end-of-life care was important, communication, and then quality of care. Again, we have patients who are dying, and there's oftentimes these same patients who are dying who are at rural hospitals who are getting transferred to tertiary care centers primarily because there's no further management available for them. We know that these long-distance transfers can actually increase stress, PTSD, so post-traumatic stress disorder, and generalized anxiety, as well as decreased quality of death and dying among these family members. And we also know, once again, that if a patient knows they're dying, they oftentimes prefer to die at home. And so that's kind of the focus of the special subgroup of patients that I've been trying to improve our overall care with. And that are these critically ill patients who are at outlying hospitals, who are referred to our tertiary care ICU, who have an increased risk of death. They need to be aware of their increased risk of adverse events, and that this form of communication that I've been talking at length about that is so important doesn't occur with this particular group of patients until after they've transferred. And oftentimes, due to the distance that's traveled, it sometimes occurs even days into their critical illness or their transfer to our ICU. And so this was kind of my way of trying to put it all together. My arrows seem to be a little messed up. I apologize for that. But so we have a critically ill patient. We know that structured communication can improve quality of care. And my goal was to somehow figure out how we can do all of this to increase satisfaction, decrease burden on the family, and decrease inappropriate use of the ICU among patients who are traveling from long distances from rural hospitals to our tertiary care center. And so that will bring me to this pilot study that we did. And this was several years ago. So when I was a fellow, I was kind of concluding this project. But basically what we thought to do was, what if we used telemedicine? So we have this telemedicine technology here that we've been using. And what if we were to use this to conduct family conferences? And what we did is we did a pilot study for 1 year, and we just, and it was really just, it was a quality improvement project at that point. So all we had at that point was retrospective data when I came in. It had already been done for about 6 months when I started. And what it was is, when a physician from an outside hospital or referring hospital called us, if we thought this patient was at high risk of death, we would then try to conduct a telemedicine conference. This is the data that we got from this, and what this slide shows is really everything in one. But we conducted about 12 conferences in about a year, so in a little less than a year actually. So that was about a one conference a month. And then this just gives you an idea of the kind of patients that we were looking at. The age varies, the diagnoses varies, and we have a very good mix of gender as well. But if you could look at table 2, which is I think what was the most interesting outcomes of this particular quality improvement project, was of the 12 patients that we had these conferences with, eight of the 12 actually transferred to our institution. And of those 8 patients, really 7 of them transferred back to their hospital for end-of-life care. So there's something to be said about the communication that was occurring but we didn't have for this particular study were the details of what was involved in each study. But there's something to be said in the fact that once we established, that these patients got the maximum therapy they could here, we were able to return them back to their hospital for their end of life. And then here it goes back to the prediction, kind of our prediction ability. 10 out of the 12 patients who had these conferences did actually die within 30 days, and that's only the mortality data that I have is actually within 30 days. What we did obtain from this little pilot study was lots of limitations. They were very concerned. There was a lot of technical limitations, meaning we were still very new at using this within our referring hospitals and really understanding how to get our telemedicine unit set up. They're very concerned about having clinician coverage to be able to do this all the time. There was concern about whether this would be reimbursed. And then the next few things are the things that I kind of focused on in my next steps going forward were people were really worried that using telemedicine was going to make family members think that we were, in some way trying to defer them from coming here, or they were by using telemedicine, they were going to feel like this lack of face-to-face interaction, and that was going to be very bad. And then also, physicians were worried about the fact that they were making these diagnoses or these recommendations without really having seen the patient themselves. And so with all of that data moving forward, I decided that in order for us to really adequately implement this program here, we needed to know what our stakeholders' understanding of telemedicine was for this particular process. Like I said, it's been used clinically here at Fletcher Allen in Vermont for teleconsultations, but for communication purposes, purely for family conferences, this was the first time that we had been doing something like this. And so I thought understanding our stakeholders' kind of ideas was important. So how we went about the next step to establish this program was we created an educational video for the Fletcher Allen Rural Palliative Care Network, and that's kind of a YouTube, the link to see it on YouTube. It's about a 12-minute video, and it shows from beginning to end what a telemedicine family conference would look like. It also presents us with some options as to what family members could then decide after this conference. So this YouTube, I'm pretty sure I put the website up properly, but you can also if you just Google Rural Palliative Care Network, this video comes right up. But anyhow, after watching the video, we had the participants, and these participants were critical care nurses and any physician who can really accept into our ICUs, were asked to fill out some open-ended questionnaires about what they thought about this process. And so I'm kind of nutshelling the results because I don't want to be, I don't want to go into too many details, but basically we can divide, so we did a qualitative analysis on all this data, and basically you can divide the perceptions into what we would call benefits and barriers. And some of the benefits that clinicians thought would occur were things like satisfaction. So they truly thought that family members would actually feel satisfaction with care, knowing that they had, their physician on one side, and then these referring physicians on the other side truly felt that they were getting as much care as possible. They thought that the knowledge they were getting, so knowledge that, say, for example, dialysis would not help a patient, was really important, might really be important for them. And they also thought that communication, so that this early communication is a great way to establish rapport with these patients before they come over, if indeed they were to come over. So those are kind of the benefits that they thought and examples of what each of those three domains meant. And then within barriers, I think very understandably, the biggest barrier that everybody was worried about was time. Where's the time in the day to conduct a telemedicine family conference when you're busy running a very busy service? Or what are referring physicians going to think about this? Are they going to think that we're undermining them, or that we don't believe what they have to say? And then again, there was the question of technology, and then logistics. How do we get all the invested folks, in the room at the same time? And how are we going to do that in a timely manner? And so that's essentially kind of the what we understood as our stakeholders' biggest issues. And so in order to kind of get past all of that, what we did is we did some more in-servicing on these. We talked about, I went through to all of the physicians who would potentially be participating in these studies, and we went over how to use the telemedicine, setup. We talked about how we can do this in a timely fashion by having one pager that goes off every time there's an admission, and that we had our operators be aware of this process as well, so that we can really kind of help out with the barrier of technology and logistics, at least. With regards to perception, I thought it was very difficult for us to really know what referring physicians thought about using telemedicine in this way. And with regards to time as well, like I said, that first pilot study, we only had retrospective data, and so we couldn't tell them how long a conference would take. And so I wanted to delve into this a little bit more and really understand. So what I've learned about trying to start a project is, as great as I thought it was to just use telemedicine to start as a new kind of consultation process, you have to get buy-in from everybody. And in order to get buy-in from everybody, you do have to take kind of steps. And these steps are slow. They've been in some way tedious for me, but I've loved doing it every step of the way. But the next step that I took was I then did a prospective study. So that was where I did a prospective study of this telemedicine for family conferences. So started actually collecting data. So my aim for this project, so I can kind of give you an idea of what we did, is we assessed whether telemedicine could feasibly be done to conduct early family conferences. Mind you, we did it for those 12 patients, but those were kind of picked out. We hand-picked those 12 out of the year based on who was available and timing. And so, is this really available? Is this something we can do as a readily available consultation service? And then also, my second aim was to gather data on the experience that people were having. So all participants, physicians from within our institution and outside institutions, family members who participate in these conferences, and really understand, what did you think about telemedicine? How did it make you feel? How did that conversation go? And what were your real perceived limitations now that you've gone through the experience? And so again, it was a prospective qualitative data. The inclusion criteria was very loose so that we can really kind of open it to anybody. And it was, if either the transferring or accepting physician thought this patient was really at high risk of death and they thought they would benefit from an early family conference, let's go ahead and try to initiate one of these calls. And then if there was also so I, as the kind of PI on the study, was able to listen into most all conversations. And if by chance physicians didn't think that these patients were at high risk, I calculated an acute physiology score, it's called a simplified acute physiology score. And if they met up a percentage that meant that they were at high risk of death, I would just remind them that this consultation service existed. And then once we got consent from everybody involved, the conferences were actually audio taped. All of them were audio taped and few were videotaped if I was able to obtain consent. And the reason I did that was I thought that it was that a family conference via telemedicine is a novel idea. And so really understanding how family members physically respond to that in that space, I thought was very important as well. And so really getting as much rich data from listening to what they had to say and watching how their behaviors was an important part of really moving forward with telemedicine for family conferences. And then finally, we did some follow-up phone interviews and questionnaires, and I also did just some basic understanding of their levels of post-traumatic stress disorder, anxiety, and quality of communication scores. Again, not comparing it to anything, but really just getting a baseline idea of what these folks, how they looked in general. So I also collected some quantitative data. So the quantitative data were things like time from the call to conference, time from the total time at the conference, and then the number of participants in each conference. And then again, the qualitative data was truly the experience of the participants. And so my interviews afterwards were also audio taped, and it's just transcripts upon transcripts of understanding what their experience was. So the basic results is in a year we had 25 requests that were potential conferences. Of those 25 requests, 10 actually were completed conferences. So 10 of these conferences I have full data on regarding what occurred during the conference and the post-conference interviews. Interestingly, I thought that some of the timing really, I think it's very helpful because folks were really worried about things taking forever. And the average time from the initial call that our operators receive to start of the conference was about 1 hour and 35 minutes. It should be noted that nowhere during this time was our transport was stopped. So we were still planning on bringing family members over, but in the meantime, while we were waiting for, say, our critical care services to arrive there, we would then conduct these family conferences in the interval period. And the average time to actually conduct a conference from the moment we started with introductions and ended with a final plan was only 13 minutes for all 10 of these conferences. very interesting point, and not specific to telemedicine, but I do think it's something that is interesting, and I'm going to delve into more as I analyze my data some more, are that 15 of the potential conferences, so the ones that didn't receive the 15 of the 25 requests, 40% of those patients actually did not transfer without a conference, which is shocking, but it also just goes to tell you, once again, back to that first line of communication, and physicians we're not really doing it at a timely manner. And so what ended up happening was, by me just being on the phone saying we wanted to talk to them, then the local physicians were then talking to them about these really difficult conversations. And so without us getting involved in any way, 40% of the patients decided actually not to transfer and stay at their local hospitals. So just a quick understanding of these patients. The average age of these patients that we were seeing was about 70 years. Majority of them were male. Overall, we had 42.8% of them transfer. These are of the 10 conferences that we did have. 42.8 of them did transfer to our institution. And once again, I think we're doing a pretty good job with identifying 30-day mortality, because it was about 85.7% mortality rate within 30 days of the initial phone call. And here's just a few examples and kind of ideas of what it looks like, or what the patient population looked like. And by no means would I go through everything, but the ones that I highlighted are the ones that did have a conference. And these were cases where this was a patient with who developed pancreatitis but has a history of metastatic lung cancer. And so they were supposed to be coming to our institution for management of the pancreatitis, which we talked to the family and said, what we would do is very conservative management. We did end up having a conference here, and then the patient transferred to Fletcher Allen, but then died here 9 days later. And so you can see that the purpose of the conferences, the telemedicine conferences, were truly to improve communication. They're by no means to defer transfers. We were always more than willing to take patients, but what we wanted to do was not delay a goals of care discussion. And I do think that when you look at our timing, dying 9 days later with a patient who was probably actively dying, we think that those are relatively good numbers, and that potentially this early conference did have some benefit, and we can talk about that data in a minute as well. And then I'll see if I can, if you look at this other patient, so this is a patient who was extremely ill, the 43-year-old male. He basically had cerebral anoxia, and so was brain dead. They decided they did not want to have a conference. He was transferred to our hospital, was still at hospital day 91 before he was transferred to a long-term facility for further management. And so once again, though the mortality rate wasn't there, if you look at kind of how grim the prognosis was, there's still quite a lot of morbidity involved with these patients. And then as we started getting, I think a little, if you go back to here, so these were the beginning ones, and then I started training more of the physicians in doing more structured communication, I think we started getting a little bit better. And I don't mean better because we were having conferences and they weren't transferring, but I do think that there's something to be said about these folks who are acutely ill and dying, and then we had a family conference, and a lot of them decided to stay at home with hospice in their local institution. And some of these folks, I don't have their hospitals with them here, but are coming from about 5 hours away, and so for them to be able to die at home with family surrounding them, I think is a significant benefit. So what did we understand from that study? So what we took back from that is it's definitely technically feasible. Not one time was I consulted that the machine was not working, or that I was unable to set up the telemedicine with the referring hospital. There was one patient who, unfortunately, they did not have telemedicine at their institution, but we actually ended up having the phone call, did it by speakerphone, and so that worked out. But that was not included. He was not actually included in my study. It does take less time than we expected, and so far it's hard to really be able to put on a PowerPoint the qualitative data, but that rich qualitative data that I was talking about so far with all the interviews we're getting a lot of favorable response. Family members feel that they're extremely well supported using telemedicine. They definitely feel that there's a lack of attachment they feel to physicians because it's not face to face, but they do feel that the visual representation of a physician from an outside hospital is far better than several quotes that say, well, it's much better to hear there's nothing that we can do seeing them say that than hearing that on the phone. So I do think that as these themes pan out, we're going to see a lot of family members responding very positively. And with regards to referring physicians, the experience has been even better because by using telemedicine in this setting, it actually enhances the patients and their families' belief that their local hospital is doing everything they could, because that's what we would do, right? We would sit and discuss and say, I understand, that your family member is dying, and I think that Dr. So-and-so is doing everything he can, and I truly don't think we would do anything more than he's doing. He's doing everything we would do. And those comments have really helped strengthen our relationship with our partnering hospitals or the hospitals that refer to us. And so once again, I think we're from the qualitative aspect of the study, we're seeing a lot of really good return from this so far. So, and again, with regards to those patients who are not coming, I think the preliminary data is confirming that palliative care communication is just not occurring early. That's a big project that we're still working on, trying to figure out how to. It's a lot about education, and we're working on that. Some of the barriers from this particular study that we did notice is that it's extremely difficult to do a research study on telemedicine because getting consent is difficult. It's hard to say, hey, we'd love to do telemedicine, and we'll do it, but is there a way I could videotape you as well? That's very difficult to do. I will say that there was about 2 patients who decided who did end up having conferences who were not included in my study as well, because they did not want to be part of the study, but we still offered them telemedicine consultations. And so I think maybe when the research aspect of this project goes away, the research kind of designation of this process goes away, it's going to be even easier to identify conferences. Additionally, identifying conferences early was a big issue, so it was hard to remind people over the course of a year, don't forget this consultation service exists. And so I feel that over the last year or two, it's building more momentum. People are understanding it more, but again, it's a novel use of telemedicine. And so getting buy-in is still what I'm aggressively working on. So, and so now to kind of talk to you about the ongoing research. So again, this is a stepwise approach to really formalizing this here. And I think the best way to get buy-in from higher ups that this is a purposeful use of telemedicine and that there's going to be a benefit to this is, we know it's doable, we know it's feasible, we know that we've overcome a lot of the clinicians' perceptions of what's going on. We understand now the experience, and so now we've been able to really kind of hone down what a telemedicine family conference should look like based on the qualitative data, based on what families said they wanted to hear, based on what families said they appreciated about telemedicine. And so using all of that, we've really kind of refined this telemedicine intervention into something that I'm very excited about, because it's my next study, which is now, again, figuring out a way to get buy-in from everybody, and that is to show improved outcomes in patients. And so what we're embarking on now is a prospective, non-randomized outcomes trial where we're using this refined telemedicine intervention. So it's now a structured approach conducting this conference, and then the structured format of it has come from all of the data from my previous study, meaning the qualitative data, understanding what family members wanted, what they didn't like about telemedicine, and trying to adjust that to this new intervention. And then now we're going to compare outcomes, so real clinical outcomes. We're going to look at patients and family members who receive this telemedicine intervention to matched controls of folks who do not receive that here at this institution. So these outcomes that we're looking at are, again, among family members, are post-traumatic stress disorder 6 weeks, and then again 3 months out, anxiety disorder 6 weeks and 3 months out, and then overall quality of, if our family members have, if the family member died, then quality of death and dying. And this is, again, comparing matched controls, and then finally quality of communication scores. The intervention is now being performed by one person only in an effort to reduce the bias. That person is me, but it's one person only, and that's in an effort to really, the next step from here would be to really make this a multi-center trial, and we're trying to reduce bias by everybody trying their own way by doing this by one person. And so just for those of you who happen to be in the audience who might be, from a referring hospital and who is considering using this telemedicine consultation service, it should just know that the recruitment starts now. Anytime, except for when I'm doing things like this, I'm able to participate in these conversations, and it's day and night, again, depending on what our schedule looks like. So with that, I'm going to kind of get ready to conclude this, but I think that what I've taken, so from where I started years ago, where this was just kind of a dream and an idea, I think there's definitely a lot that's come out of this. And one is, we know that telemedicine, it can be used in this format to conduct family conferences. So that's great. We're excited about that. The thing I love to tell physicians out there and our nurses at referring hospitals as well, is it doesn't take as long as we'd think. If you have 10 minutes or 15 minutes, we can all get together in a room, and it really changes these patients' outcomes. And so knowing that, it's worth our 10 minutes. So far, participants on both sides, clinicians and family members, have all responded very favorably, and look for that data to come out very soon. Again, it's all qualitative, so there's no way for me to be able to show you that on PowerPoint, but and so far there's no data yet on regarding clinical outcomes, but we are starting that study. And so hopefully, I think, this is my personal opinion, that even a negative study is a good study, because I think that we have to parse out what it is that improves. I'm not looking to improve clinical outcomes among patients. I think patients who are dying are going to die. I think the outcomes that I think this telemedicine intervention is going to see are down the line. If we can reduce stress among family members, and we're reducing healthcare costs down the line for those family members, I don't think that looking at clinical outcomes among patients themselves is the answer. And so that's why I'm focusing on the families. And so with that, I'm going to conclude. And I want to thank everybody very much for taking the time to listen to this. As you know, this is as I probably explained to you, this is a project that I'm extremely passionate about. And I'm very excited to be able to take any questions.
Thank you so much, Dr. Menon. We so appreciate you sharing your novel study, and we are very hopeful that you continue to find great outcomes and meaningful outcomes as you move forward in this second phase. So with that, can we take a look at the chat and see if there are any content-specific questions first in there?
Okay, I'm looking. Back of it. I don't see any questions.
I could share a comment.
There's a comment. Would you like me to read the comment?
Sure, that would be great.
Okay, so there's a comment regarding, can I say from who or no?
I would keep it on the down low.
Okay, so comment stating that it's a valuable tool, especially for patients in remote areas. It's a huge impact on patients whose insurance covers to get them to higher level of care, but then these patients get stuck at this higher level of care because they can't get home. And I would have to obviously agree. So from my standpoint, this is where the money is when we're working in medicine, it's all about the patient, and it's the hardest thing in the world as a physician to see a patient who's die alone because their family members couldn't make it out, this far. And so I think that's kind of where all of this stemmed, and I would have to agree with this comment. It's really hard with these folks who are at home. And then there's a question, potential for billing. So yes, you can now. We are able to. So when I started this, a lot of the issues were about reimbursement, and you can get reimbursed in multiple different ways. from our standpoint, we can bill critical care time for those folks if they do end up coming to our institution, and add on to the time that we do when they get here. So we are able to do that with this telemedicine intervention if we have documented that.
Is that has reimbursement
because
laws, or is it
Vermont.
to do with Medicaid?
From what I understand, it's secondary to the Vermont laws. I believe in New York there is definitely telemedicine reimbursement that I know of, but I don't think it's specific. So you can't be specific to this kind of a consultation. It's for telecare kind of consultations. And then I'm going to kind of read the next question. So with the move towards outcome-based reimbursement, do you have thoughts on what they should consider when reimbursing for palliative care? We're talking about, I have a question for that. So are we talking about reimbursing for palliative care in general, or specific to these palliative care telemedicine consultations? Both. I think, I should clarify, I'm not a palliative care physician, and so I don't really know the ins and outs of the billings for palliative care, but I do think that when we're looking at outcome-based reimbursement, I think it's becoming a big shift is towards kind of this, when we look at HCAHPS and all of this, we're looking at our family satisfaction scores and things like that. And I think that that's what we should be focusing this type of intervention on. I'm not really sure if I have a good answer for that question, to be honest. Whether I think that this kind of intervention is going to change our HCAHPS scores within institutions, because that's what we're looking to change, is satisfaction.
What are those?
Oh, the HCAHPS. So those are the hospital kind of overall, what are those? I forget the full name for it. Do you know the full name for it?
No, I don't.
So sorry, the HCAHPS are they're what am I trying to say? They're like they're scores that each hospital gets for meeting certain criteria for priorities in healthcare right now. So for example, family satisfaction is a huge push right now. Patient family-centered care is a huge push, which is why all these patient-centered outcomes are big. So I feel like those are the things that this kind of work is going to really make a change on, and that I don't know, regarding palliative care and outcomes-based reimbursement, I don't really know if I can answer that question very well. And then the other question was whether the slides were available to share with your team members, and absolutely.
They'll probably be on the Metric website.
On the
I think,
www.netrc.org.
Yes, we will definitely share a recording of this webinar, which will include the slide set in PDF version. So yes.
That's a question I had, but it went private there, and I didn't mean it to.
And
there we go. HCAHPS, Hospital Consumer Assessment of Healthcare Providers. Thank you.
we're thinking on the same wavelength, because I just was going to mention that.
Yeah. So another question, what are some of the things families did not like about the telemedicine meeting that we were able to change? So it had a lot to do with body language and the way we had actually arranged folks to sit around the room. I think that they thought it was very, kind of almost military, because we had it in rows. And so from then on, we just left it very casual, and we do circles now. It's really helped with the circles versus the room we were in was just, we were able to do 2 seats in the front and 2 seats in the back, and family members did not like that. The other thing that I think that they didn't like was, or that they did like, but then I had to try to really encourage our providers to remember this, is they liked when we were looking at the big screen versus the webcam. So little things like that, but they definitely appreciated us looking at the big screen, because they felt like they were really being heard that way.
It looked like eye contact?
It looked a little bit more like eye contact. I think actually when you look at the big screen, it almost looks like more eye contact when you look at the big screen, but it was very clearly that they were looking at nothing versus looking at them and understanding it. And so there was that disparity that I think a lot of, when we started this project off, we thought, look at the camera, because then it looks like we're looking directly at them. And in fact, it's actually, they wanted to know they were being listened, they were being heard. And so, yeah, that was one of the things. Some people just didn't like it, though. I mean, very clearly there were some responses that they just didn't like it. They felt that the telemedicine was too robotic and it was not, personal. And so the way we try to go about that is our first initial step now for the family conference is to do introductions and really get an idea of who each person is in the room for just 5 minutes. And that's kind of how we are trying to get past that, but we'll see if that's working with this data. So there's another question, which is there is an Army pilot using virtual patients to help train physicians to interact with patients via telehealth. Yes. So I will say that there's that, and with all of my passion about trying to improve communication, there's also a recent study, I want to say in chest, from some ICU physicians over in Washington, that they're really big into the palliative care, right, because they have to interact differently, so that are big into the palliative care, and it was regarding I don't know if anybody's heard of the OncoTalk, but it's like a standardized way of how to deliver bad news. So they did that among residents, and they started them in their intern year, and then they did this prospective study to see if we could improve outcomes, and it was a negative study, which was devastating to me and to, I think, those who believe that if you really practice and practice and practice, we can learn to communicate better. But I think, again, it's taking a step back, and they keep looking at patient outcomes, and I don't think that's the outcomes we need to be looking at. We need to be looking at satisfaction outcomes, and that's not really what they did. So.
Mm-hmm. Well, it looks like all of our chat questions have been answered, and I actually unmuted everyone's line. So if you do have a question, we do have a couple more minutes left with Dr. Menon if folks would like to verbalize those questions. Great. Well, we're getting some fantastic feedback from your talk today here, Dr. Menon, and we so appreciate it. Thank you to everyone who was able to join us today. We do hope that you share this with colleagues who were not able to join us. I know that I plan to. I learned some fantastic things, and I'm really looking forward to working as a TRC with you moving forward and learning what you learned, Dr. Menon. So with that said, I think we will close for the day. Thank you so much, and have a fantastic afternoon.
Thank you.
Bye, everyone.